Hello, my dear friends. I'm Dr. Vaishali Bharambe. Finally, we're going to talk about lesions of medulla oblongata, for which, of course, we have to talk about the blood supply. Okay, so let's begin. Always remember, ascending and descending tracts pass through medulla oblongata. Okay, it's important to know at the level of the lesion whether they were crossed or uncrossed, whether they cross above the level of lesion or they cross below the level of lesion. Parallelly, the cranial nerves fibers run horizontally, and therefore whichever cranial nerve is affected helps you to localize the site of the lesion. Okay, as we do this lecture, okay, you will understand exactly what I'm saying. Come. To study a lesion, understand and revise the blood supply first. So, blood supply of medulla oblongata. Here you're looking at the base of the brain or the lower surface of brain. Here is your medulla oblongata, which receives blood supply from the vertebral artery. You can see the two vertebral arteries uniting to form the basal artery here. They're giving rise to posterior inferior cerebellar artery, two arteries uniting to form anterior spinal artery. It also gives rise to posterior spinal artery, not seen in this diagram. All these arteries supply your medulla oblongata. This supply is in the form of some zones. Okay, for example, the anterior spinal artery supplies the region which is on either side of midline, called as the median zone. The vertebral artery and the posterior inferior cerebellar artery supplies this lateral zone, and the posterior spinal artery supplies the posterior zone. So medial zone, lateral zone, and posterior zone. Blood supplies anterior spinal artery, vertebral and posterior inferior cerebellar artery, and posteriorly posterior spinal artery. Clear? Right. So let's begin with the first lesion if the medial zone is affected. The lesion is called as medial medullary syndrome or the Dejerine syndrome. So the anterior spinal artery is affected in this case this side. So lesion that gets produced is somewhat like this. Okay, this is the area which enters into ischemia. So what are the tracts affected? The corticospinal tracts of pyramid, the medial lemniscus, the hypoglossal nerve. So the pyramid is affected, the medial lemniscus is affected, and the hypoglossal nerve is affected. If they are affected, what symptoms will you see? Okay, come, let's understand that. So when there is a pyramidal lesion here, you will see an upper motor neuron lesion of the corticospinal tract, paralysis of opposite side of the body. You must be wondering how. How did you come to this conclusion? Why upper motor neuron? Why not lower motor neuron? And so on. Ideally, these questions should strike you. So come, I'll show you how to calculate this. It's like mathematics. Okay. So here you're seeing the cerebral cortex, the brainstem, and the spinal cord. Fibers from the cortex are descending down, crossing in the lower medulla and entering into the spinal cord. This is the body of the neuron. This is the axon of the neuron. Remember, it's one single fiber. Okay. So this is called as the upper motor neuron. Okay. So the body is here. The axon is here. This whole thing is the upper motor neuron. This neuron will hand over impulse to the neuron in the spinal cord or the neuron in the brainstem, which gives rise to cranial nerves. All these neurons are called as lower motor neurons. Okay, they are called as lower motor neurons. So now let's understand that if the lesion is over here, which is the fiber cut? Is it the lower motor neuron or the upper motor neuron? Clearly, it's the upper motor neuron of the corticospinal tract. And therefore, you will see the corticospinal tract affected. Now, just go back. Can you see that this lesion is above the level, above the crossing, right? So, let's understand what are the symptoms of the patient. The patient will come with symptoms on the opposite side. The lesion is on the left side. You will see the symptoms of the lesion on the opposite side because lesion is above the crossing. Okay, right. So what will you see? The patient will lose ability to perform skilled movements. Babinski sign positive. Superficial abdominal reflex is absent. Cremasteric lip reflex absent. Okay, so these are symptoms you are seeing on the opposite side of the body. It is an upper motor neuron type of lesion. Why? Because you saw the upper motor neuron was cut. Now, medial lemniscus. Here you are seeing a lesion of the medial lemniscus. What symptoms will you see? So let's understand what is this medial lemniscus, how is it formed. There is fine touch felt in the body. It's carried by the first order neuron to the level of medulla, relayed into the nucleus gracilis, nucleus cuneatus in the medulla, axons of which act as second order neurons, crossing the midline, ascending up to the contralateral thalamus, relaying there. Third order neurons from the thalamus relay the sensation in cerebral cortex. This is where fibers are crossing. If the lesion is here, then the patient will feel loss of sensation on the same side or on the opposite side, obviously on the opposite side. Okay, so what you're seeing is hemianesthesia on the opposite half of the body. Medial lemniscus, therefore, you will see opposite side of the body losing tactile localization, unable to judge degree of pressure, astereognosis, inability to judge weight, loss of vibration sense, loss of conscious muscle joint sense, and so on. All this is seen on the opposite half of the body because lesion is above the level of crossing. Okay. Now let's talk about the hypoglossal nerve also being damaged. Now this hypoglossal nerve is damaged or has a lesion. Therefore, what will you see? Muscles of tongue are paralyzed. Is it same side or opposite side? It's the same side because you do not see any crossing here, right? So, is it an upper motor neuron or a lower motor neuron lesion? Let's take a look. See, this is your corticospinal tract and corticobulbar tract. Okay, this is an upper motor neuron. It is stimulating this at the level of spinal cord and these nerves, nuclei at the level of brainstem. Now, these are all called lower motor neurons. If the lesion is here, okay, who is affected? It's the lower motor neuron which is affected. Therefore, it will be an element lesion, a lower motor neuron type of lesion. There is no crossing and therefore you will see it on the same side. So what symptoms will you see? You will see the tongue being deviated to the affected side. Why is it deviated to the affected side? Because opposite side muscles are overacting, pushing the weaker side, okay, causing the tongue to be deviated to the affected side. So, but the lesion is ipsilateral, not contralateral, because there is no crossing here. So that's the 12th nerve affected. So what do you see in medial medullary syndrome? You see corticospinal tract affected, you see medial lemniscus affected, you see 12th nerve affected. How is it affected? Contralateral hemiplegia, contralateral hemianesthesia, ipsilateral paralysis of muscles of tongue. Therefore, this is alternating hypoglossal hemiplegia, alternating. Ipsilateral one type of lesion, contralateral another type of lesion. Alternating hypoglossal hemiplegia. Because hypoglossal is affected, you know that the lesion is somewhere in the medulla and you know it's a medial lesion because hypoglossal nucleus is always found in the close to the midline. Right? Okay, so let's move on to another type of lesion, this time a lateral zone. What happens if the lateral zone is affected? How will the lateral zone be affected? Take a look. So, this kind of lesion is called as a Wallenberg Syndrome. It's suppose the posterior inferior cerebellar artery is affected somewhere here. So, the lesion will look like this, okay, affecting the nucleus ambiguous, affecting spinal tract and nucleus of trigeminal, and affecting spinal lemniscus. A very interesting combination. I'll tell you what happens in this patient. Come. Because nucleus ambiguous is affected, all the muscles of the branchial arches, okay, supplied by 9th, 10th, 11th cranial nerves will be paralyzed on the same side. That means 9th and 11th are affected. That means paralysis of muscles of soft palate, pharynx and larynx on the same side. Okay. So that's nucleus ambiguous. Is it upper motor neuron or lower motor neuron? I think we've done this discussion. It's going to be a lower motor neuron because the nucleus which is giving rise to the nerve itself is damaged. It's a lower motor neuron type of lesion. See? This is where the lesion is, so it's an element lesion. What about lesion of spinal tract and nucleus? Which side will you see the lesion? What will happen? The patient will lose sensation of pain and temperature on the same side of the lesion. Loss of pain and temperature sensation on the same side of the lesion, on the face. Okay, so loss of pain and temperature sensation from the face on the same side. What about spinal lemniscus? Spinal lemniscus was carrying lateral spinothalamic tract, which was carrying pain temperature from the contralateral side of the body, right? So loss of pain temperature on one side, loss of pain temperature from the body on the other side, okay? So face one side affected, body another side affected. This is called alternating hemianesthesia. Alternating hemianesthesia. One side face affected, one side body affected. Alternating hemianesthesia. Okay, typical of Wallenberg syndrome. Sometimes the lesion can be expanded, it can be so large, in which case the inferior cerebellar peduncle is affected, the vestibular nuclei are affected, and therefore what symptoms will the patient get? Inferior cerebellar peduncle. So you will have symptoms similar to cerebellar symptoms, cerebellar asynergia, hypotonia, ataxia. Vestibular nuclei will be affected. Patient will have vertigo, nausea, vomiting, nystagmus, which are all related to our balance, right? So all these symptoms will come in when there is a wide Wallenberg lesion. Let's talk about another condition called Cerebello-Pontine Angle Syndrome. If you recall, this is the Cerebello-Pontine angle, where the cerebellum pons and the medulla oblongata meet, where the eighth cranial nerve enters into the brainstem. Okay, so what happens is sometimes at this point the eighth nerve may have a vestibular schwannoma. It may have a tumor. Okay, so the tumor will begin to compress the following structures. It will compress the eighth cranial nerve, the inferior and middle cerebellar peduncles, which are right here. This is the middle cerebellar, this is the inferior cerebellar peduncle. It will compress the spinal tract nucleus and it will compress the facial nerve right there. All these structures are affected by this and coming under the purview of Cerebello-Pontine Angle Syndrome. What will the patient come with? So we've already done this. If it's a 8th nerve lesion, patient will have tinnitus, progressive deafness, cochlear nuclei affected, nausea, vomiting, nystagmus, vestibular nuclei affected. Cerebellar dysfunctions, okay, such as intention tremor, imbalance, ataxia, dysmetria, and so on. Patient will have spinal tract and nucleus being affected, so ipsilateral loss of pain temperature from the face. Facial nucleus paralysis, ipsilateral paralysis of muscles of the face. Okay, so all this is again a lower motor neuron type of lesion. So this is Cerebello-Pontine Angle Syndrome. Let's finally talk about, suppose there is just a growth of a tumor in the posterior cranial fossa. See, posterior cranial fossa is here. It's quite a limited space. If the tumor begins to grow here, there is increase in the pressure in the posterior cranial fossa. When pressure increases, the neural tissue is pushed out of the only possible hole available, okay, which is the point of least resistance, which is your foramen magnum. So the medulla and the cerebellar tonsils are under pressure to exit out from this foramen magnum. Patient will come with symptoms of headache, neck stiffness, paralysis of 9th, 10th, 11th, 12th cranial nerves. Okay, now you will be tempted to do a spinal tap or a lumbar puncture to see, what is going on, and maybe you can check the CSF. But the moment you do that, the CSF pressure falls. The moment CSF pressure falls, the whole thing causes a catastrophic precipitation of herniation. So never do a lumbar puncture in these cases. So this is what you should be aware of when you are going in for a suspected posterior cranial fossa tumor. So what did we learn today? We learned about 4 lesions related to medulla oblongata alternating hypoglossal hemiplegia, also called medial medullary syndrome, lateral medullary syndrome, Cerebello-Pontine Angle Syndrome, and posterior cranial fossa tumor. So these are some of the lesions affecting medulla oblongata. With this, I complete this medulla oblongata part of our lecture. We will now move on to pons in the next lecture. Meanwhile, I strongly advise you to go solve the MCQs that I have given along with this, solve the short notes, try and familiarize yourself, revise the entire medulla oblongata again before you move on to the higher center, which is pons. I hope you're enjoying this lecture series, okay? And I'll see you in pons then. So if you're liking my lectures, do like and subscribe to my channel. Bye.